Good morning, everyone. So nice to see so many young faces in the audience today, in spite of being a Sunday morning. Thank you very much for that kind introduction. And before I begin, I'd also like to thank IMA for teaming up with ISHPT and conducting this wonderful conference, and thank Siddesh and everybody at IMA for inviting all of us here for this meeting. It's really been a very well organized, very good meet. Nashik is a beautiful place, lovely climate, lovely scenery as we drive down from Mumbai. So it's been a real pleasure being here. The venue is great, the food was good, so I really don't think there is any minus to this. Now, I start with my talk. How do I put this? So I'm going to talk on heavy menstrual bleed today, which is not strictly a hematology topic, but has a lot of hematology involvement in this, a hematologist's involvement in this. Let's go. So by definition, menorrhagia is heavy and prolonged bleeding without any abnormal periodicity. That is, the periods occur at the right time. It is measured by a blood loss of more than 80 milliliters during the menstrual cycle. And as we know, the average cycle usually lasts for about 29 days, with bleeding episodes normally lasting 2 to 7 days, but can be increased in these patients. And as you can see, the causes are multifactorial, right from hormonal imbalance to local causes in the genital tract. And of course, a very important part is the bleeding disorders. The FIGO has endorsed, or the International Federation for Gynecology and Obstetrics, have proposed a classification system that divides acute uterine bleeding into two types of causes, the structural and the non-structural causes. The annual prevalence is 53 per 1,000 women. So it is not by any means rare or less common seen in the general population. And it is seen in about 20 to 30% of women who present to the gynecology OPD. So the classification which is proposed for actually identifying these disorders is called the Palm-Cohen classification. It is actually an acronym. It is classified into 9 categories, of which 2 parts are there, the structural and the non-structural. So you can have a polyp, an adenomyosis, a leiomyoma, and malignancy, which are the structural causes, and you can have a coagulopathy, ovulatory causes, endometrial causes, and iatrogenic due to IUDs and chemotherapeutic agents, anticoagulants, etc., and the not yet classified causes, which are the non-structural causes. And you can actually then classify any person coming to you with a menorrhagia as AUB. Say, if you say AUBP, it will probably mean due to polyposis, or if you say AUBC, it means it's due to a coagulopathy. There are a few other causes as well, such as medications that interact with platelets and coagulation factors, as we know, anticoagulants and aspirins. Then you have contraceptives, which can also cause bleeding. You have some certain drugs such as tamoxifen and certain antidepressants, antipsychotics, and corticosteroids. So the history is the clinical screening tool. It is a very important aspect to diagnose these patients, because it is actually a clinical screening tool to determine if the patient will benefit from further coagulation testing. And you can say that a positive screen includes any of these following. A heavy menstrual bleed, of course, is mandatory, and you can have one of the following conditions, which is a postpartum hemorrhage, a surgery-related bleeding, or a bleeding associated with some dental procedures. And if the patient has 2 or more of these following conditions, such as bruising twice a month, epistaxis once or twice a month, frequent gum bleeds, and a family history of bleeding symptoms, it very strongly points to the fact that this patient needs a coagulation workup. A physical exam is done for assessing any life-threatening conditions that can cause acute blood loss, anemia, and hypovolemia. A speculative examination is necessary to rule out any genital tract abnormalities, and a biannual examination is done for uterine abnormalities and enlargement which are caused by leiomyomas or cervical abnormalities which are caused by polyps or due to cervical cancer. Approximately 90% of AUBC is identified as a coagulopathy with the use of this structured history and screening. So this is a very important aspect of diagnosing these patients. In the general population, approximately 10% of women have menorrhagia, not a low percentage. Although it is more common, although it is so common, a specific cause is identified only in less than 50% of the patients that come. The most common bleeding disorder in women with menorrhagia has been known to be von Willebrand disease, which is seen in 13% of women who come with menorrhagia. And a close second is the platelet function disorders, which are also very much present, but maybe not diagnosed as much as they should be. These patients also come with bleeding after some dental procedures and postoperative bleeding and postpartum hemorrhage. So all these will go or contribute towards the diagnosis of an inherited bleeding disorder. 1 in 5 women with menorrhagia actually have an inherited bleeding disorder, and this group of disorders therefore should be considered in women who suffer right from menarche, who come to you with menorrhagia since menarche. The initial laboratory tests for an underlying bleeding disorder is usually a CBC. CBC is not really very contributory, but it helps to rule out a thrombocytopenia, and which may be the cause of the bleeding, and an anemia which is caused by the bleeding. At least 2/3 of the women with menorrhagia or von Willebrand disease first come to you with an anemia. It is very erroneous to assume that a normal CBC, a normal PT, and a normal APTT will rule out any underlying bleeding disorder, and I think many previous speakers also have reiterated this. The sensitivity of a prolonged APTT for von Willebrand disease is less than 40%. So I think that is one of the reasons why these disorders are so difficult to diagnose and why these women mostly don't get any answers to their menorrhagia. Then you have the severe but rare non-X-linked hemophilia disorders, that are those deficiencies other than the deficiency of factor 8 and 9, such as deficiencies of factors 1, 2, 5, 7, 10, and 11. Here the PT and APTT are very good at diagnosing, because if you will have a prolonged APTT, you will go in for a mixing study, you will see that it is some kind of coagulation factor deficiency, you do the common coagulation factors 8 and 9, you find them normal, then of course you have to refer them further to a specialized referral lab to do the other less common factors, to quantify these factors. Therefore, testing should include not only PT, APTT, but also von Willebrand factor antigen. You have the risdiplam cofactor assay, which is necessary to diagnose some types of von Willebrand. Factor 8, ABO type is also very important. The IV bleeding time and the platelet function test. Now, the IV bleeding time is controversial. I know many people don't do it, but in some settings it really helps, especially if it is done in a by the standardized template method. I wouldn't recommend it for everything, but not for like a pre-surgical or a pre-operative check, but it can help in certain conditions. So with that, I'll just go through a case which is a prototype case of these disorders, and will explain to you how these people usually land up. So here we have a 42-year-old lady who who has 2 children and comes with complaints of heavy menstrual bleeding since menarche. And it lasts from 8 to 10 days, and she has a lot of lethargy and discomfort during that time. Now, she is come at 42 years also, she's still coming. So obviously she has seen many people right from menarche. Her symptoms have not been dealt with or not been solved. So she keeps coming, and even at 42 years she has come. On examination, no petechiae, no ecchymosis were noted. Pelvic examination showed normal genital tract. A Papinicolau stain was also done, which was normal. A curettage of the uterus done showed a normal secretory endometrium. And the routine lab tests were also almost normal. Hemoglobin was 12.5 grams, which we consider normal in a lady, in a female patient. The WBC platelet counts are all normal. The bleeding time was 9 minutes, which was like a borderline high. Otherwise, hormonal functions, thyroid function, etc., all were normal. nothing was found in this patient, so she was asked to come back after 1 year. After 1 year also, CBC was similar, PT was 12 seconds. However, her PTT was prolonged at this time, 31.1 seconds, and the BT at now was more than 20 minutes, done by the template method, was more than 20 minutes. It was decided at this visit that if all these are normal, if the bleeding parameters are normal, then a diagnostic hysteroscopy would be advised in this patient. However, when she came, a pelvic USG showed no uterine or pelvic pathology, ovaries were normal, kidney function, liver function, all were normal. All the other hormones such as the prolactin level, FSH level were normal, progesterone levels were normal. So therefore, a diagnostic hysteroscopy with repeat endometrial sampling, which was advised if all these results were normal, was now deferred in view of the prolonged APTT-BT with normal platelet count. A bleeding disorder was strongly suspected, and at this time it was decided to do a proper thorough workup of the von Willebrand panel rather than to pursue any other modality of investigation. The von Willebrand panel which was done showed that she had a normal resuscitant cofactor activity, and the von Willebrand antigen was mildly borderline reduced, 46%. We normally take from 50% onwards as normal. A multimer assay was done of the von Willebrand factor, which was normal. And at this time, a diagnosis of mild type 1 von Willebrand disease was given to this patient. Patient was advised oral contraceptives and or endometrial ablation. She refused both, so she was given DDAVP, nasal spray, and she responded. And why I present this case is because the patient said that she has learned to live with this condition. Now you can imagine for so many years, she has learned to live with a condition which she has to experience every month of so much pain, discomfort, loss of working days, and irritability with the family, with the children. So many other social factors come into this. So just for a lack of diagnosis, this case has been prolonged for so many days. And retrospectively, this patient had a long history of menorrhagia. Bleeding time was 9, which was borderline high at that time. And von Willebrand factor is notorious or famous for not being easily diagnosed. So these early findings did indicate that she had a coagulopathy, but adequate follow-up was not done. So this is a typical example of how diagnosis of menorrhagia is delayed in these patients. Laboratory tests that can be recommended in such patients are a CBC, in which you can find low platelets and thrombocytopenia, or in type 2 von Willebrand disease. Patient may have iron deficiency due to menorrhagia. Otherwise, CBC is fairly unremarkable. PT and APTT are done. If you have factor deficiency, it's very easy to diagnose, but von Willebrand, once again, APTT is not sensitive enough. Severe forms may have a deranged APTT, but most of them which come in the spectrum of mild to moderate may not show a prolonged APTT. TT is normal, fibrinogen assays are normal. Bleeding time is neither sensitive nor specific, but if prolonged, definitely has a good positive predictive value. And if it is done, as I say, by a standardized method. Some people have used the PFA 100, 200. It is good for screening, but it is far too expensive, not used so much in our country, and not always helpful. So not recommended. It's very important to do hormonal assays such as even thyroid stimulating hormone, etc., because hypothyroidism is known to be associated with acquired von Willebrand disease. And in such cases, thyroid replacement can rectify the deficiency. Creatinine also should be done to rule out any kind of uremic bleeding. Now to come to the diagnosis of von Willebrand disease. Why is it so difficult to diagnose? Is because there are so many different types of von Willebrand diseases, right? We have type 1, type 2, and type 3. Type 1 is characterized by a partial quantitative deficiency, and type 3 by a severe quantitative deficiency or almost absent von Willebrand factor. And the type 2, all disorders are due to qualitative defects in the von Willebrand factor. And these are again further subdivided into 2A, 2B, 2M, and 2N, in which 2A and 2M both have decreased von Willebrand factor dependent platelet addition. Then there are tests to diagnose this. However, in 2A, you may have a selective loss of the high molecular weight monomers, whereas in type 2M, you will not have any loss, you will have normal monomers. Type 2B is characterized by increased affinity for platelets by the GP1B complex. Type 2N is shows a markedly decreased binding affinity to factor VIII. So there are these different types of von Willebrand, and as you can see, the type 1, type 2A and type 2B all have an autosomal dominant inheritance pattern, whereas 2M, 2N and type 3 are all inherited by a recessive pattern. And you can see that the features are all differing in all of them. Therefore, many different tests are required to identify all these disorders. So for type 1 and type 3, the important test that one should do is the von Willebrand factor antigen. So in type 1, it will be partially reduced, whereas in type 3, it will be almost absent. You will almost not see a von Willebrand. Sometimes you wonder if your test has gone correct or not, or you are making some technical errors, but you actually see 0% von Willebrand antigen in these. Additionally, you have a very low collagen binding assay in type 3. In type 2, you have in type 2, all the type 2s, the antigen will be normal because the antigen quantity is normal, but the function is abnormal. So you have a normal antigen, but in type 2 as well as in type 2M, 2A and in type 2M, you will have collagen binding assay is abnormal. And in type 2B, you will have the Rieckhoff assay, which is abnormal. So these are some of the tests that are done to diagnose von Willebrand factor deficiency, and that is why we don't diagnose, because some of these tests are very specialized and most labs do not do all the tests. So it is recommended that at least a factor antigen and an activity assay should be done. And if you are doing platelet aggregation studies at your lab, then you can diagnose type 2B by doing the ristocetin binding assay. The von Willebrand factor antigen levels are usually immunoassay tests, which are very sensitive. The normal, as I told you, we take from 50 to 200 units per delta liter. It is, as I said, undetectable in type 3, reduced in type 1, and normal in type 2. A deficiency which is less than 30 units is very easy to diagnose. But a deficiency which is between 30 and 50 is always difficult. You may not have a prolonged APTT also in these, and you may need to repeat it because von Willebrand factor is known to increase in many other conditions, even it's an acute phase reactant. So you need to repeat this at some stage. A Rieckhoff assay, when it's done, a ratio of the Rieckhoff assay with the von Willebrand antigen assay, it is seen that if it is less than 0.6, it is suggestive of a qualitative defect. If it is more than 0.6, which nearing 1, it is suggestive of a quantitative defect. Now, the Rieckhoff activity in this, what we do is ristocetin-induced platelet agglutination is seen. That whether platelets agglutinate, or actually it is platelet addition even with ristocetin, not agglutination. And if this is defective, then you say that the Rieckhoff assay is abnormal. It is the ability of the patient's plasma to agglutinate platelets in the presence of ristocetin. This is also a not a very easy test to do to begin with, and not very commonly done in most of the labs. So you may have to refer it out. And therefore, also the variation is a lot in these tests. Then you must do a factor VIII assay, because a completely low factor VIII is diagnostic of type 3 von Willebrand, and along with undetectable levels of von Willebrand factor antigen. However, factor VIII is normal in 2A, 2B, 2M, etc. Ratio of the factor VIII to von Willebrand antigen, if it is more than 1, it is suggestive of type 1 deficiency. If it is less than 1, it is suggestive of type 2N deficiency. Now, it must be noted that patients who have the blood type O have a 25% lower von Willebrand factor level. So therefore, this again becomes very difficult to interpret in terms of the bleeding of the patient. If you have the bleeding, the first thing one needs to know, if the von Willebrand factor antigen is low, you must get a blood grouping done of that patient. If it is O, it is a known fact that they will have a 25% less antigen. And this has to be adjusted for patients with bleeding symptoms, and sometimes when it is almost difficult to actually diagnose whether it's low because of because the patient is O blood group or it is actually low, you can go in for a genetic studies. So far we've been talking of the von Willebrand factor. Historically, the most common bleeding disorder so far we have seen in menorrhagia is the von Willebrand factor, which is known to have an incidence of about 3 to 36%. However, as awareness and ability to diagnose platelet function disorders has improved, it has been suggested that they comprise the most frequent inherited bleeding disorders in this population, with an estimated prevalence of even more than von Willebrand. Now, this is a recent study which has come out with this statement that it may even be more common than the von Willebrand factors. These authors estimate it at 4 to 44%. Now, platelet disorders causing menorrhagia can, as we know, be quantitative or qualitative, and they can be either inherited or acquired. Oh my. Quantitative platelet defects include ITP, TTP, thrombocytopenia due to medication, leukemias, etc. The principle of these tests I won't go into as I'm running short of time, but platelet aggregation tests depend upon the absorbance changes. When you add platelets to an agonist, they clump and the more light passes through this sample. So there is a change in the absorbance of light which is recorded, and that's how you see whether the agonist is acting or not. Now, just to quickly go through this case of a 16-year-old girl who presented with menorrhagia since Menarche with a drop in hemoglobin and feeling tired, no family history. On examination, she was pale with a low hemoglobin. Coagulation profile showed was normal with normal platelet count. Therefore, she was advised a platelet aggregation study. And you can see here that the platelet aggregation response to to arachidonic acid is, here there's only arachidonic acid, is really low. There is no curve as one expects, and even to ristocetin is only 47%, whereas we require at least 80% to call it a normal curve. And here you can see that the platelets are not at all reacting to high and low doses of ADP and to collagen. So very clearly this patient has a platelet function defect, which is the Glanzmann's thrombasthenia, which is actually due to a loss of factor GP2B3A complex on the surface of the platelets, which can be confirmed on flow cytometry. So here on flow you can separate out your platelet population from the RBCs on an FSC-SSC log. And CD4161 denotes the GP2B complex. Here you can see your patient has no 41 and no 61, complete absence. Therefore, it's a confirmed case of Glanzmann's, whereas GP42B, which is glycoprotein 1B, is present in these patients. And you interpret thromboasthenia as 3 types. Type 1 is patients with less than 5% of GP2B3A. Type 2 is 5 to 20%. And type 3 variants have a normal antigen, but their platelet function test is abnormal. There is a mismatch between the two. And here we have a patient of Bernard-Soulier syndrome in whom the type 1B will be reduced, but here we have a patient where we've segregated the platelets. Your platelets are showing 41, 61. And when we reacted with 42B, we see that all of them are positive for 61, whereas a part of the platelets are negative for, they're just positive for 61. This patient is a patient of Bernard-Soulier syndrome who has been transfused. Therefore, not all, otherwise you would have found an absence of this GP42B in all of the platelets. Here, however, the donor platelets show the presence of 42B, and the patient's platelets are all negative. You can see they're all only 61 positive and not. So there are many other platelet function defects such as the storage pool disorders and the von Willebrand factor assay. One very good thing about doing platelet aggregation is that if you have type 2B von Willebrand disease, then your platelet aggregation to ristocetin low dose is abnormal. It is very high. So many von Willebrand disorders we pick up on doing platelet function tests. And additional coagulation studies that one can do if your initial screen is initial coagulation screen is normal, is you can do factor 13 assay, and you can do specific assays for the antifibrinolytic factors such as the alpha-2 antiplasmin and the plasminogen activator inhibitor. So these are specific assays for these tests. And there is another very important group of recessively inherited coagulation disorders, which I already told you about, which are distinct from the commonly occurring ones, and they are very, very rare in the population, therefore nothing much is known about them. Menorrhagia is very common in all these women. Additionally, if you have recurrent miscarriages, you will know it is either a afibrinogenemia or a factor 13 deficiency. And diagnosis for specific coagulation factors, assays, as I told you, you have to send to some referral lab. Factor antigen assays are not necessary in any of these. We only have to see the coagulant assays. The activity assays are important because that is the one that reflects what you see clinically. The baseline treatment for all of these is oral antifibrinolytic therapy, oral contraceptives, intranasal DDAVP, etc. And accurate diagnosis of a coagulopathy should be made even when the patient responds to any of these, because it is crucial later on for the patient. If the patient requires any surgery or anything, patient needs to know. The patient should not feel that I'm not bleeding anymore and I'm fine and I will not land up into any more trouble. This is not strictly true. Patient can bleed at the time of dental procedure or other surgeries. There are many other alternative therapies which are given to these patients, such as vasopressin analogs, then hemostatic agents such as lithium sialate, selective estrogen receptors, etc. But the point to note here is that the lack of a high level of efficacy of individual medications reflects the multiple pathways involved in endometrial hemostasis. So patients variably respond to all these, so you have to give the patient what the patient does respond to. So to conclude, patients with menorrhagia should have a CBC-PT-PTT, fibrinogen von Willebrand panel performed as part of the initial workup, and platelet aggregometry to evaluate platelet function should also be considered in these patients, especially if all the screening tests are normal. Platelet flow cytometry used to further confirm certain specific diagnosis. Then there are certain other modalities of treatment such as thromboelastogram can be used as a supplemental test, has been found to be normal because it shows you platelet defects. However, you cannot use it exclusively. You have to use it in conjunction with other assays. PFA 100, as I already told you, is not very specific and therefore not recommended. Platelet function disorders continue to be difficult to diagnose, and this algorithm is based on the latest evidence which is available for workup of patients with menorrhagia. Thank you.